Good morning, everyone, and we are joining for a new presentation. And I would like to welcome you all for this new presentation. So, the purpose of this new presentation is to highlight the importance of knowing basic things about chronic kidney disease and acute kidney injury. And as you all know, the number one cause for chronic kidney disease all over the world is diabetes, followed by hypertension. And everyone thinks that controlling the blood sugar would prevent diabetic related complications or end organ damage. And they never look into screening of diabetic complications. As the kidney diseases are asymptomatic, that is, they don't show any symptoms up until the last minute. And we assess the functions of the kidney with estimated GFR. And if we take 100% as normal and up until it becomes 10%, it does not show any form of symptoms. So the patient would not seek any medical help and they would not realize that their kidney is failing up until the last minute. It is us, the medical team, who should be vigilant enough to detect the kidney diseases early. So as we all know that diabetes is the primary culprit for chronic kidney disease, and all the patients with diabetes should undergo an annual screening on diagnosis or at the time of diagnosis and annually thereafter. So as this slide highlights that they should undergo not only the screening for diabetic nephropathy, but also diabetic retinopathy, peripheral vascular disease, diabetic neuropathy, and heart screening with lipid profile and things like that. So this has been highlighted in this slide, and in the left-hand corner, it highlights the chronic kidney disease prevalence and the causes for chronic kidney disease. As you can see, 42% of the time it is diabetes and 18% of the time it is hypertension, followed by chronic glomerulonephritis. When it comes to acute kidney injury, it is the sepsis. Almost 50% of acute kidney injury is due to sepsis. And for your surprise, could you guess the second most common cause for AKI? It is medications or iatrogenic causes. And if you have never heard of renal drug handbook, and if your mobile phone is not having a freely available copy of the renal drug handbook, then we are all part of contributing to this iatrogenic form of acute kidney injury. And we are all doing medical nephrectomies. Why do I say that? So if you don't adjust the medications doses according to the current EGFR of the patient, then because of reduced amount of clearance with renal impairment, it could cause toxicity and cause further damage. So every medical person should have a copy of renal drug handbook, as we use British National Formulary for dose adjustments. And we can't give underdosing, it will be a subtherapeutic dose, and we can't give overdosing because it can cause toxicity. And when it comes to renal impairment, it should be the renal drug handbook that should be directing us the appropriate dosing with estimated GFR. If we don't use that, So we are all doing harm to the patient, which is against our primary medical ethics. So this is a sample of screening for the diabetic complications, and this has been used in National Hospital Colombo, and we could use these forms for screening. And this is the local guideline which emphasize the importance of screening at diagnosis and then annually. And the second important thing is that everyone thinks that screening should be with serum creatinine, which is a late marker of renal impairment. As evidenced by you can donate a kidney, still your serum creatinine or the estimated GFR does not change, which indicates that serum creatinine itself is a late marker. So then the question arises, what is the early marker? Early marker is the proteinuria, which could be quantified and assessed with the help of the albumin creatinine ratio of a urine spot sample or protein creatinine ratio of a urine spot sample, or else in the resource limited settings, urine full report. And if it shows more than a trace amount, then that indicates that there is proteinuria. And as highlighted earlier, EGFR less than 60 would definitely indicate that it is a chronic kidney disease. So why do we have to pick the renal or diabetic nephropathy early, or early detection of diabetic nephropathy is important? So by the time patient becomes symptomatic, patient would have progress into a advanced renal impairment like CKD stage 5, where they become symptomatic. But if we pick the patients early in the initial stages, so there are measures which could slow down the chronic kidney disease progression with controlling of proteinuria. What are those measures? As highlighted in this slide, SGLT2 inhibitors, metformin, RAS blockade, all these would contribute for slowing down the chronic kidney disease progression, and that has to be introduced as early as possible. And nowadays, the latest guideline highlights that every patient with diabetes should be started on metformin along with SGLT2 inhibitors. We don't have to wait up until the patient develops proteinuria to start SGLT2 inhibitors. So they can start on at the time of diagnosis itself to prevent diabetic nephropathy prevention progression. And there is an additional or novel medication that has shown some proven benefit. And the current concept is the diabetic nephropathy is driven by three pillars or three mechanisms. One is hemodynamically contributing to the diabetic nephropathy progression. Another one is metabolic abnormalities contributing to the diabetic nephropathy progression. And the important part is the inflammation and fibrosis, which has not been touched, because the hemodynamical mechanism has been counteracted with ACE inhibitors or ARBs or dihydropyridine calcium channel blockers and SGLT2 inhibitors. And metabolic components has been tackled with SGLT2 inhibitors, GLPR1 blockers, and metformin, and optimization of the blood sugar control. Whereas the inflammation and fibrosis part had not been touched. So they have found that a novel mineralocorticoid antagonist shows an anti-fibrotic and anti-inflammatory effect, so that it helps in reducing the progression of the chronic kidney disease due to diabetic nephropathy. So that has to be introduced before the patient goes into estimated GFR less than 20 to reduce the progression. So I had taken this opportunity to highlight the importance of detecting diabetic nephropathy early, because I'm not expecting everyone to know each and every aspect of nephrology. But when it comes to CKD, you should know the first two common causes for CKD and how to pick them early and how to manage them. So that is why I have highlighted the diabetic nephropathy part early, because that is us, the medical team, who should pick the diabetic nephropathy early and then introduce those medications to slow down the chronic kidney disease progression so that we can reduce the numbers of patients progressing to end-stage renal disease needing dialysis. That is about chronic kidney disease. And second thing is about acute kidney injury. As I have highlighted in my second slide, that common cause of acute kidney injury is the sepsis. Almost 50 percentage. It is our local data from the Sri Lanka, from a single center analysis. They have found that 50 percentage of AKI is due to sepsis. Not only in Sri Lanka, but worldwide, it is the commonest cause. So at least we should know how to tackle with sepsis-induced AKI. So sepsis-induced AKI occurs most of the time due to the infection-related factors and also due to the hemodynamic instability. And as we all know, it is a major cause of morbidity and mortality in critically ill patients in the hospital setup worldwide. And the important thing is that their prognosis improves greatly with early identification and management. So, how do we diagnose whether this AKI is due to sepsis? So, sepsis induced AKI is a diagnosis of exclusion. So, there is no definitive investigation to tell us that it is due to sepsis. So, if we can exclude all the other common causes of acute kidney injury, then we can conclude that if the patient is also having sepsis, it could be due to sepsis. So how do we do that? So once a patient presents with presentation of sepsis and he has an AKI, so from the right hand side, you do a radiological assessment to find whether there is any post-renal causes that could give rise to an obstructive uropathy. If it is not so, so what are the things that you look for in the scan, ultrasound scan? That is the kidney sizes and whether there is any evidence of obstruction, that is hydronephrosis or hydroureter. And if you suspect a renal, if you suspect a urosepsis component, whether it is complicated UTI or not, as like whether there is any infected collections like renal abscess or something which needs to be drained. So these are the things that you assess initially, post-renal causes. Then we look for the pre-renal causes and we assess the volume, we assess for volume depletion and whether the blood pressure has been dropped and whether there had been already pre-existing cardiac dysfunction. So we'll have to assess, or liver dysfunction, we have to assess. And if these are not obvious, then we look for the intrinsic renal causes and get a thorough history, asking for whether there had been exposure of any form of nephrotoxins or whether the patient had been affected previously by primary renal diseases. Right, when a patient presents with an acute kidney injury, do you have to immediately get the help from the nephrology or renal team? No. So once the AKI is confirmed, I don't have to go back to the diagnosis of acute kidney injury. Everyone is familiar with the definition. And I would like to highlight, so when you go by the definition, you need to be careful. So the diagnostic dilemma arises. So here, as you can see, there is a criteria for serum creatinine rise within 48 hours with 26.5 micromoles, or else 1.5 times base, 1.5 times from the baseline within 7 days, or less than zero point 0.5 ml per kg per hour for 6 hours. So if you just take this definition into clinical practice or practically, so if a patient has not passed urine for almost 6 hours, has to be considered as AKI. So here you need to know the difference between anuria and acute retention. Anuria means the kidney has not produced urine. So that is what this definition means. And sometimes patient could be in acute retention. How do we differentiate? So you will have to feel for the bladder enlargement in the suprapubic area, and you will have to confirm it with the ultrasound scan. There is no enlarged bladder or full bladder present with the ultrasound evidence. And you can also introduce a urine catheter to see whether there is any retained urine within the bladder. Or else you can ask the patient to urinate and see and calculate from the time he has passed urine, and if it is less than 0.5 ml per kg per hour, then only you can consider it as acute kidney injury. Right, once the diagnosis is confirmed as acute kidney injury, then you will have to shout at yourself before going to the renal team or shouting at them. So what is this shout principle highlights? So that is treatment of the sepsis, which stands for the S, and H stands for the volume correction. O stands for excluding obstruction, U stands for urinalysis, and T stands for toxins. That is, nephrotoxins should be excluded. And you have to shout at yourself. So most of the time, the sepsis-induced AKI could be managed with this principle. And when we have to go back to the renal team, so if there is persistent oliguria, so which is highlighted in the left lowermost corner, persistent oliguria, ongoing deterioration, and there is indication for dialysis, then you will have to go back to the renal team. Or like if you suspect some other atypical forms of AKI, like with the low platelet, like atypical uremic syndrome, and the patient has also progressed to CKD, AKI stage 3, then these are the indications that you have to go back to the renal team. Basically, if there is a need for need for the dialysis, you'll have to go. Second, if you think that there is an atypical form other than sepsis-induced AKI, is there like hemolytic uremic syndrome, TTP, and if the disease, so AKI is so severe, it's in the stage 3, then you'll have to get help from the renal team. An important aspect of managing the AKI is understanding the pathophysiological mechanism. Once you understand the pathophysiological mechanism, it is easy for us to manage. And the only thing that we need to do is counteract whatever the pathophysiological mechanism that is happening. So there had been 4 major mechanisms that has been found to attribute to sepsis-induced AKI. So the commonest one, if you take 100 patients, 90% of the time, 90% of the time, it is due to the sepsis which has progressed to a hemodynamical instability. And because of patient has gone into a shock stage and his perfusion pressure has been on the lower side, renal perfusion has been on the lower side, which has led to a pre-renal element of AKI. So this is the commonest mechanism which gives rise to a sepsis-induced AKI. And the second mechanism is if the sepsis is within the renal tract, yes, it could give rise to an AKI, but not the lower UTI. It need to be upper UTI like pyelonephritis. And the third mechanism is sepsis is somewhere else in a distant septic focus. And because of this systemic inflammatory response, the patient could develop AKI, like infections like diabetic foot wounds, community acquired pneumonia, whereas they have not gone into a state of septic shock still because of this inflammatory process that has been going on that could indirectly cause a AKI, whereas the management is same. You continue to treat the sepsis and the serum creatinine would come down along with the inflammatory markers. And the important and uh, mechanism which everyone is not familiar with is this fourth one, that is called infection related glomerulonephritis, which has been previously named as post-streptococcal glomerulonephritis. Now the terminology has changed to infection-related glomerulonephritis. Why the terminology has changed? Initially, they thought that it is only the streptococcal which is causing this inflammatory type of glomerulonephritis. But nowadays, they have found that not only streptococcal, it could be staphylococcal, it could be viral, it could be parasitical, it would be fungal infections which could give rise to inflammatory type of glomerulonephritis and leading to AKI. Another thing is that initially they thought that infection and there's a lag period and then they develop an inflammatory type of GN. Now the current concept is while the patient is having a infection itself, simultaneously they can develop inflammatory type of GN called IRGN. So that is why the new terminology has formulated. So as I have highlighted, we would see one by one what are the mechanisms. So first of all, the commonest mechanism, 90 out of 100 times, the patient with the sepsis goes into a septic shock, which give rise to a systemic vasodilation and then leads to a hypotension. The blood pressure drops and the perfusion pressure drops, and which reduces the renal perfusion, and that would lead to a pre-renal AKI. And also, even without uh, this hemodynamical mechanism, additionally, there could be direct injury to the microcirculatory dysfunction, and endothelial injury could also contribute to the acute kidney injury. And as I have highlighted as a second mechanism, sepsis is within the renal tract, and which should be evidenced by. So I have seen so many patients diagnosis card which mentions that AKI secondary to urosepsis. But when we look for an evidence in the diagnosis card, it would not be there. For an example, we are practicing evidence-based medicine, so we need to give evidence that this is this. So how can we say that it is due to AKI is due to the urosepsis? So the UFR should be positive for pyuria and the culture should be positive for some organisms. And if you see the mechanism that directly the microorganism or the infection affects the renal parenchyma and cause infection and inflammation, and that gives rise to AKI. So basically, if it is AKI due to urosepsis, the patient should have a evidence of UFR evidence and culture should be there. But surprisingly, the evidence comes from scan or radiological, which would have mentioned AKI or pyelonephritis. So there is no clear-cut radiological evidence only. So pyelonephritis is a clinical diagnosis. The patient should present with fever with chills and rigors, and he should have loin pain, and his urine analysis should be positive for pyuria, and his urine culture should be positive. Why do we do the scan then? So we do the scan just to see whether the kidney sizes are normal, which indicates that there had not been a chronic kidney damage previously. And so whether there is any evidence of obstruction, any stone disease or any tumors or anything which is causing the obstruction which has predisposed to the urosepsis. Another thing is that whether this urosepsis is a simple urosepsis or complicated urosepsis like renal abscess or anything which need to be drained for source control in addition to the antibiotic treatment. So that is why we do So it's not like doing the scan and which shows which it would be commented as pyelonephritis, and then we treat it as pyelonephritis or AKI. So those are clinical diagnoses. So we need to be careful. And the third mechanism, as I have highlighted earlier also, so there's a distant septic foci which causes a systemic inflammatory response like diabetic foot wounds, pneumonias, and this systemic inflammatory response triggers kidney injury despite the infection being somewhere else. And this AKI would definitely settle with treating of the primary infection. At the same time, we may have to support the kidney functions. And as I have highlighted earlier, so the fourth mechanism is infection-related glomerulonephritis. So why this is important? Because all the other mechanisms where you just introduce the antibiotic treatment and control the source, and then the AKI also settles. But it would be opposite when it comes to infection-related glomerulonephritis. That is why everyone who is handling a septic patient should be aware about this mechanism. Here, the sepsis would become controlled. How do we know that sepsis becomes controlled? So we monitor for the fever spikes, it's settling nicely, and patient clinically improves. And then inflammatory markers like CRP comes down nicely. And the serum creatine also would have come down due to the third mechanism. But at some point, the things would reverse. So the improved serum creatine might start to rise again despite CRP being on the lower side. And the urine output could come down. So that is why you need to monitor the urine output. You need to monitor the renal functions even after the settling of the infection for some time to identify this infection related glomerulonephritis. And if you need objective evidence that it could be infection related glomerulonephritis, uh, you can do ASOT, which would be elevated in streptococcal infections. And also you can do the complement levels, whereas C3 would be low and C4 would be normal in most of the infection-related glomerulonephritis. And if you need more confirmation, you can do a renal biopsy to confirm it with renal biopsy, which would show a neutrophil infiltrated glomerular proliferative glomerulonephritis, which could confirm that it is due to infection-related glomerulonephritis. And this type of mechanism would need a nephrology input. Why? Because most of the time it is an oliguric AKI that would develop as a result, and the patient might need a dialysis support. So we need to closely monitor for indications for dialysis in these patients. But there had been, like, if you ask me, it is the inflammatory process that has been giving rise to this type of AKI. So is there any place for a immunosuppression? So the current evidence says that it has not shown any proven benefit. Whereas we treat the infection and support with dialysis as needed, and then it spontaneously recovers. So what are the management strategies? As I have highlighted for all the three other mechanisms, we have to resuscitate. Resuscitation need to be quick because kidney is the very important organ. I say it as an important organ. Why? Because it is the most susceptible organ for ischemia other than brain. So that is why God has given it a auto-regulatory mechanism. It can sustain ischemia for some time, but if it is prolonged and if the auto-regulatory mechanism is overcome, and then it would lead to a serious ischemic damage to the renal tubular epithelial cells and give rise to acute tubular necrosis, which would take a while for it to recover back spontaneously. Up until that time, we might have to support with dialysis. So we need to be quick in restoring the perfusion pressure, hydration, as we have highlighted in the shout mechanism, treatment of the sepsis with appropriate empirical antibiotics or broad spectrum antibiotics, and then give the hemodynamic support and maintain the perfusion pressure with fluid treatment and vasopressors. And important thing is to control the source, and we need to identify the source. So everyone makes this mistake. Everyone thinks that starting the antibiotics is the primary management step in controlling the sepsis, but everyone forgets about the source control. I can give you an example. So when you are a farmer, and if you find a cow or bull eating your crops within your paddy field, which has been protected by a fence, then first thing what you would do is chase away the cow or the bull out of the paddy field. But is that it? What is the important thing that you need to do? You need to find from which part of that protecting fence the cow or the bull has entered the paddy field. Otherwise, what would happen? So it can come back again, and your crops are at risk again. So source control is important as much as the appropriate antibiotic treatment. So how do we decide? So the next slide would introduce about empirical treatment, appropriate treatment, and things. I will come back to that. At the same time, so as I have highlighted, so all four mechanisms, and importantly fourth mechanism, might need a renal support up until the sepsis is under control and the AKI is recovering. So we'll have to monitor the urine output and consider dialysis as needed. So this slide, everyone thinks that it is a mistakenly added slide. No. As clinicians, when it comes to sepsis, I have highlighted other than the hemodynamical support to maintain the perfusion pressure, we need to go ahead with the antibiotic treatment. So when a patient comes with a sepsis, we don't know which organism is causing it, but if we identify the septic foci, and with our previous experiences, previous trials, we have found that this could be the commonest organism which could give rise to this type of sepsis. So we start an antibiotic to cover that antibiotic. At the same time, we need to cover broadly, not narrow down, as like this multi-barrel has done. So when you fire a missile with a multi-barrel, so it just clear out everything. So it doesn't worry about whether there are humans, animals, or trees. It just clear out that area. So it's broadly clears it out. But if you are a clinician, and if you know what are the common organisms that could give rise to this type of infection, and if you are familiar with the local antibiotic guidelines, then you can narrow it down to narrow spectrum antibiotics. Or else, if you are unsure, then you have to cover gram positive, gram negative, and at the same time, anaerobic cover. So gram positive cover usually with amoxicillin, gram negative cover with gentamicin, and anaerobic cover with flagyl. So which is equal and almost to broad spectrum antibiotics like meropenem, ceftriaxone, omeprazole, tazobactam, like antibiotics which are costly. So when it comes to cost effectiveness, you can either follow this step. But if you are a clinician, then if you know that this is the septic foci, then you can narrow down the uh, antibiotic. So for an example, when it comes to a dialysis line related infection, so we cover for the gram positive because we don't know whether it is a gram positive organism or gram negative organism. So we give vancomycin for gram to cover the gram positive organisms, and then we start gentamicin to cover the gram negative organisms. Whereas when it comes to line infection, anaerobic cover is not needed because we know that with experience that anaerobic infection does not occur with line infection. But when it comes to oral cavity or genital cavity, then we might have to cover up with the anaerobic cover as well. So this type of antibiotic is called an empirical treatment of antibiotic. So what is this empirical type of antibiotic? So we start these broad spectrum antibiotics as early as possible, right? And these empirical antibiotics had to be selected according to the local guidelines. So from our country, we have a microbiology, College of Microbiology has published a local guideline, and you will have to be familiar with the empirical antibiotics. Empirical antibiotics. I'm repeating the empirical antibiotics. So what is this empirical means? So we have been using these empirical antibiotics for ages, but we don't know the meaning of empirical. Empirical means that the exact wording means blind. So we are treating blind treatment. So when do we see the exact organism and cover that organism, then it is going to be appropriate antibiotic treatment. So up until that time, it is a blind treatment. So how do we come to know that what is the appropriate antibiotic? So we need to take an appropriate cultures, and we need to identify the septic foci and take appropriate cultures and get an antibiotic sensitivity pattern to tell us which is the appropriate antibiotic, which could give which could be done in day 3 or day 4 according to our microbiologist setup. So up until that time, we are giving blind treatment. So that you need to keep in mind. So you need to be looking for the culture reports and antibiotic sensitive pattern to rationalize your antibiotic by day 3 or day 4. But most of the time I have seen for the line infection also, you would have continued both gram positive and gram negative cover for 2 weeks or 3 weeks, where you don't have an idea about which organisms, what you need to do to rationalize antibiotic by day 3. And can you wait up until day 3 with the same antibiotic and patient is deteriorating? No, definitely no. So you'll have to escalate. For an example, if you are giving some form of a simple antibiotic like penicillin for soft tissue infections and patient is deteriorating, you can't wait up until the culture report is back by day 3. Patient would deteriorate and die even. So sepsis kills. So you'll have to escalate. So you'll have to go up on the broad spectrum cover, and you'll have to top it up to merapinam, opipracillin, tazobactam according to the clinical status and the antibiotic guideline. And then by day 3, once you get the culture report, you can either de-escalate or keep the same antibiotic. So this is how you have to treat the sepsis. And when you give an appropriate antibiotic treatment, is that enough? So when we see a sepsis-induced AKI which is not resolving, so what are the probable causes that could give rise to a delayed renal recovery in a sepsis-induced AKI? So if you don't give an appropriate antibiotic and if you don't maintain a perfusion pressure, it would give rise to an pre-renal element of that. And if you don't give an appropriate dosing of that antibiotic, and if you don't give a appropriate duration of that antibiotic, then definitely that would give rise to a delayed renal recovery. And as I have highlighted earlier, so the second commonest cause of acute kidney injury is these iatrogenic causes of medication induced. So you will have to be familiar with renal drug handbook, which explains or which gives you guide on the dosing of antibiotics or the medications doses according to the EGFR. And if you are in a high resource settings, and if you are using some form of a narrowed therapeutic index medications like vancomycin, gentamicin, if you have the facility of monitoring the level, so that would be the ideal thing to do to reduce renal toxicity or nephrotoxicity. But in our countries, how do we use these medications? When it comes to vancomycin, we space it out to every third day, and the same thing with gentamicin when it comes to renal impairment. So as we don't have drug monitoring trough levels. So, as a conclusion, sepsis-induced AKI is multifactorial and it requires early identification. Why do I say multifactorial? It is not only the sepsis that is giving rise to the AKI, but when a patient becomes septic, he would not take enough orally and he would be dehydrated. And then he would have continued his usual routine medications, and no one would have advised him on sick day rule. So, what is sick day rule? So that is, you have to advise the patient when he becomes sick, and he should withhold all the hemodynamically altering medications like SGLT2 inhibitors, ACE inhibitors or ARBs, metformins, diuretics. These medications act by altering the hemodynamical mechanism. And if the patient becomes sick, then again, as we have highlighted earlier, so that sepsis itself alters the hemodynamical mechanism. So it's like if we continue the same medications while the patient is sick, then it is like burning the fuel on fire, right? So that is why. So if we continue, so that also attributes. And patient would have been started on some form of nephrotoxins like NSAIDs, because patient would definitely complain of myalgia, then the GPs throw out NSAIDs at the patient. So that could have also given rise to this. And then if the patient's or renal tract is obstructed due to some other reason, so it could also give rise. So most of the time, the sepsis induced AKI is multifactorial. So we'll have to identify those, and we'll have to withhold and counteract mechanisms in addition to source control and antibiotic treatment. And how do we diagnose sepsis induced AKI? It is by a diagnosis exclusion, because we don't have a unique pathognomonic investigation to tell us that this is septic induced AKI. So how do we do that? So we exclude post-renal causes, pre-renal causes, and intrinsic renal causes. And then as a diagnosis exclusion, we can conclude that it is sepsis induced AKI. So when it comes to the management, it is the purely management of the sepsis, starting with resuscitation with fluid and maintaining the perfusion pressure, and then controlling the source, and then antibiotic treatment, and if needed, the patient should be on renal support. And if the hemodynamically unstable, he should be for continuous mode of renal replacement therapy with CRRT in the MIC with multi-organ support. And if the patient is hemodynamically stable, he could tolerate intermittent hemodialysis, then we can support it with that. And if we don't have a CRRT bed in the MICU, but still patient has developed indication for dialysis, we can also use a hybrid form called SLED, that is sustained low efficacy dialysis, whereas we reduce both blood flow rate and dialysis flow rate and do the dialysis, but it needs to be done for 6 to 8 hours. And important thing is that sepsis, we need close monitoring, and early nephrology consultations are key when it comes to patient prognosis. So if you all have any questions, you can paste it